Good morning. My name is David Murray. I'm the Associate Director for Prevention and the Director of the Office of Disease Prevention at the National Institutes of Health. I'm pleased to welcome you to the first of two 2021 ODP Early-Stage Investigator lectures. We created this lecture to highlight early career prevention scientists who have not yet served as a principal investigator for a substantial NIH-supported research project, but who have made outstanding research contributions to their field and are poised to become future leaders in prevention research. Before we begin, I have two housekeeping items. You can submit questions during the webinar by clicking on the chat box in the lower right-hand corner of your WebEx window. Please direct your questions to all panelists. We will open the floor to questions at the end of the lecture. The slides and video recording will be posted on our website in approximately 1 week, and each of you will receive an email when those materials are available. Our speaker this morning is Dr. Morgan Philbin. Dr. Philbin is one of two 2021 Early-Stage Investigator Awardees. She is an assistant professor in the Department of Sociomedical Sciences at the Columbia University Mailman School of Public Health. Her mixed methods research explores how sociocultural factors can drive and be used to prevent HIV and substance use among marginalized young people, particularly sexual and gender minority youth. In addition, Dr. Philbin's work examines potential social side effects and unintended consequences of substance use and HIV-related policies and practices, and their impact on young people. Dr. Philbin has conducted research on how these policies and practices influence adolescent and young adults' HIV prevention, testing, and care engagement behaviors. Her recent mixed methods work has explored barriers and facilitators to the scale-up of long-acting injectable antiretroviral therapy and pre-exposure prophylaxis. Supported by a National Institute of Drug Abuse KO1 award, she is examining now how state-level HIV and substance use policies can impact health behaviors among sexual minority youth and young adults. Dr. Philbin's research has been funded by several NIH institutes, including NIDA, the National Institute on Minority Health and Health Disparities, the National Institute on Allergy and Infectious Diseases, and the National Institute of Mental Health. Today, Dr. Philbin will speak to us about current research on antiretroviral therapy and pre-exposure prophylaxis, with a focus on the multi-level barriers and facilitators to successful implementation. She will also highlight key points that must be addressed to scale up biomedical HIV technologies in ways that maximize population health impact and reduce existing disparities related to current formulations of antiretroviral therapy and pre-exposure prophylaxis. Please join me in welcoming Dr. Morgan Philbin.
Thank you so much, Dr. Murray, for the introduction, and I want to thank the Office of Disease Prevention for providing me with this amazing opportunity, and to all of you for coming to listen. I also want to recognize and thank Dean Lisa Rosen-Metsch, who nominated me for this award. Dr. Rosen-Metsch has been an incredible mentor, colleague, and friend since I first came to Columbia as a postdoctoral fellow in 2013, and I could never have made it to where I am without her support. In addition to Lisa, I also want to highlight and thank the many people who have provided mentorship through my time in public health. I owe a true debt of gratitude to the individuals pictured here. They are some of the most amazing scientists that I know, and I'm happy to report equally amazing humans. I'm going to begin this presentation by also thanking the National Institute of Health for supporting my training trajectory, including my NIMH-funded T32 postdoc, my NIDA-funded KO1, and my NIMHD-funded loan repayment program. I also want to say a special thank you to Rich Jenkins, who's the PO of my KO1, and the R25 on HIV substance use and ethics through Fordham University, and to Gerald Sharp and Joanna Rowe, who provided invaluable support as I navigated and conducted interviews on long-acting injectable ART and PrEP within WISE. And I also want to thank Terry Sen, who's the PO of an R34 I was recently awarded based on the WISE data. As Dr. Murray mentioned in his introduction, I'm an interdisciplinary behavioral scientist, and I use multi-method approaches to explore the social determinants of health for marginalized populations. My work focuses on social structural drivers of HIV and substance use risk, primarily among racial, ethnic, and sexual and gender minority youth. While this talk is focused on long-acting injectable ART and PrEP, I have another stream of work that examines how state and local policies affect HIV and substance use risk for youth and young adults. While I will not highlight my policy research today, many of the themes that arise in that work are also relevant here. In the same ways that policies can constrain people's behavior and their ability to access certain services, the development of biomedical technologies, which include long-acting injectable ART and PrEP, can also exacerbate health-related inequalities if only certain individuals come to know about services, access them, and maintain the care they want and deserve. I'm going to begin the presentation by arguing that access to long-acting injectable ART and PrEP should be approached through a lens of health equity and health justice. I'll then provide a short background on HIV disparities and the state of the science on long-acting injectables. I'll then share a series of hypothetical case studies to describe potential barriers and facilitators to scale up, and end with some concluding thoughts. While I will provide more details on HIV later in this presentation, I briefly want to note a few things to make sure that we're all on the same page as I start. There are currently about 1.1 million people in the US living with HIV. Approximately a quarter of new infections stem from people who don't know they have HIV, and just over 2/3 come from people that know they have HIV but who are not in care. And I note these statistics for two reasons. First, they show how imperative it is for both individual level and population level health outcomes that people living with HIV know their status, are engaged in care, and receive antiretroviral therapy, or ART. People living with HIV who are virally suppressed cannot transmit HIV to a partner, which is why it is important, as I mentioned, for both individual and population level health. HIV ART currently exists as a single daily pill, and the long-acting injectable version is given monthly. The second reason I note these statistics is that they highlight the need for people who are at risk for HIV to have multiple options to protect themselves. In 2012, the Food and Drug Administration approved an oral version of PrEP for HIV. This daily pill can help reduce the risk of HIV for up to 99%, and the long-acting injectable version of PrEP would be given every 2 months, but is not yet approved by the Food and Drug Administration. The field of HIV/AIDS has produced incredible amounts of biobehavioral research and has made important advances in treatment and prevention over the last 40 years. Long-acting injectable ART and PrEP hold incredible promise for slowing the course of the HIV epidemic and helping us achieve our goals of increasing equitable access, but they are not a panacea. HIV fatigue is very real. The media is paying less attention, and funding streams have shifted or become less robust. And at the same time, people in the US and across the world are still getting sick and dying at alarming rates, particularly within marginalized populations. We must continue to apply a lens of health equity and health justice to ensure that everybody who needs HIV treatment and prevention, both domestically and globally, can access it in whatever formulation will most benefit them. This move towards increasing biomedical options is an ideal time to recenter communities and ensure that their needs are met. While invaluable, new biomedical technologies can also serve to reify social dimensions of HIV treatment and prevention. Much like we saw with the COVID vaccine, the same populations that were most at risk are also those least likely to have access to treatment. The fundamental causes of health inequality theory, developed by Lincoln Phelan, shows how novel health technologies can create disparities in health distribution that did not previously exist. This is because certain people gain access to these technologies based on factors like their knowledge, skill, education, power, and social capital. This is most salient with health outcomes that are preventable, such as HIV. We can produce new biomedical technologies, but if nothing shifts on a structural level, then these technologies will only benefit individuals who would likely remain adherent to oral ART or PrEP regardless of the formulation more generally. We must ensure that we apply this framing of fundamental causes and what we already know about disparities in the distribution of oral ART and PrEP to help facilitate equitable access to long-acting versions of these medications. I want to touch briefly on these transversal themes of the multi-level barriers to medication, how we tailor public health messaging, challenges around coercion and shared decision-making, and our need to increase confidence in science or limit biomedical skepticism, because these affect access to medical services for many different diseases, including HIV. In this presentation, I will argue that these themes will only become increasingly relevant as we expand long-acting versions of ART and PrEP, particularly given patterns that we've seen when the same expansion occurred for things like substance use treatment and mental health care. I also want to note that these themes are particularly relevant when the affected individuals are marginalized or face power differentials that challenge their ability to advocate for their own needs. Later in this presentation, I will present 3 hypothetical case studies to illustrate potential drivers and barriers to equitable scale-up, and I want you to keep these themes in mind as I do so. Also, while my talk today is focused on HIV, I want to highlight that these themes are relevant to many other diseases, including one that we are all very familiar with. On a personal note, I saw these transversal themes play out as a volunteer translator at Columbia's vaccine site. The site was initially open to everybody who received care at Columbia and was therefore flooded with people who could access the internet, had transportation, and also had the social capital to check repeatedly for vaccine slots. Some people proudly told me how they drove from up to 4 hours away. Then the vaccine site began allocating a certain percentage of slots to people who lived in nearby neighborhoods, and the demographics shifted immediately. In addition, the vaccine site began working closely with community organizations based in places like Harlem, Washington Heights, and the South Bronx to make sure people living nearby knew about the vaccine site, could sign up, and could get there. And not surprisingly, the number of monolingual Spanish speakers increased dramatically, necessitating the need for translators, which the university then supplied through volunteers and otherwise. This shift in demographics occurred because we brought people to us versus expecting them to come to us. Of note, many of the challenges we face with COVID are equally relevant for HIV testing, linkage to care, and engagement in care. As we know, there were many challenges to accessing COVID tests and COVID care, and there are acute disparities based on factors like race, ethnicity, type of employment, age, and socioeconomic status. And this figure documents the stark disparities in cases, hospitalizations, and deaths for racial ethnic minorities compared to non-Hispanic whites. I've circled every instance where racial ethnic minority individuals had worse outcomes than non-Hispanic whites, and I present this here because I want you to keep in mind when I start showing details for HIV that you will see very similar patterns. Then, with COVID, much like long-acting injectables, we had the rollout of a new biomedical technology, in this case vaccines, which we know are not reaching people in an equitable way. Even though racial and ethnic minority individuals were disproportionately impacted by COVID-related hospitalizations and deaths, they are still barely half as likely as white individuals to have gotten vaccinated. Much of this is due to the initial structuring of sign-up systems, choice of locations, and existing structural barriers around things like transportation access, language, and biomedical skepticism. Also, some of the vaccine side effects, most notably from the Johnson & Johnson vaccine, may have unintended consequences or social side effects on how people engage with future forms of injectable medication. Similar to HIV, our COVID response includes lots of public health messaging, for example, around mask wearing and social distancing and vaccine uptake with varied success. And COVID, among other things in the last 4 years, has wreaked havoc on the public's confidence in science and institutions, which has implications for the successful rollout of many other medications, including long-actable HIV. I know that many of you conduct research on HIV, but to ensure that we all have a basic knowledge of where things stand, I'm going to briefly review some of the current statistics of HIV in the US, with a focus on disparities in rates of infection and viral suppression by age, gender, race, ethnicity, sexual orientation, and geography. One of the largest disparities in HIV is by sexual identity. Men who have sex with men are nearly 80 times more likely than heterosexual men to be diagnosed with HIV in their lifetime. However, even within this, there are distinct disparities by race ethnicity. As you can see, the risk is 1 in 11 for men who have sex with men, compared to 1 in 4 for Hispanic MSM and 1 in 2 for African American MSM. I also want to highlight that people who inject drugs are at higher risk of contracting HIV. As you can see, the increase is almost tenfold higher for women who inject drugs compared to women who do not. These numbers show a stark need for PrEP and how we'll need to think about getting PrEP, whether in oral or long-acting injectable form, to the people who can most benefit. I also want to highlight the vast disparities that we see in new diagnoses overall by race ethnicity, in addition to what I just noted by sexual orientation. This figure very starkly shows the differences by race ethnicity for new diagnoses. As you can see in green, it's 42% occur among Blacks and African Americans compared to 25% among whites. And I also want to highlight how this disproportionately impacts people when you look at the rates of new infections compared to the overall US population in green. So you can see for Black individuals and white individuals, it is almost flipped, right? So the US population is much higher for whites compared to the about 30% of new cases. There are also disparities by age, and the majority of new cases occur among individuals 25 to 34. The reason I'm highlighting this is because in terms of how we scale up ART and PrEP in long-acting injectable form, it's important to think about in terms of clinical encounters that these populations may have. So for example, for many women, ages 25 to 34 are their peak reproductive years, so they may be having annual gynecological visits, which could be a good place to introduce some of these options, whereas men at this stage may consider themselves healthy and not needing to see a primary care provider. I also want to highlight the vast geographical disparities in rates of people living with HIV, as you can see here, particularly if you look in the Deep South and in Florida, and 51% of new cases occur there. Overall in the US, and I want you to look at the blue bar for this, and what this is showing is the rates of people across different categories who are living with HIV and whether they are diagnosed and know their status, whether they have received some care, and if they're virally suppressed. And like I mentioned, the viral suppression is particularly important because if somebody is living with HIV but virally suppressed, they cannot transmit HIV to their partners. In particular, in this figure, I want to draw attention to youth. This is the yellow bar, because they have a much lower rate of viral suppression than the national average, so 30% versus 56%. And based on research that I have done with youth and young adults, youth face some of the highest barriers to oral PrEP and to oral ART, and will likely face similarly high barriers to long-acting injectable versions of these modalities. But similar to COVID, we cannot change the course of the epidemic by only treating people who are easy to find, engaged in care, readily able to get to the clinic, or who live in the United States. We also have an ethical imperative to reach individuals who are the most marginalized to ensure that they have access to the same prevention and treatment tools as everybody else. While biomedical technologies are promising, they face very entrenched barriers that advancements in these technologies alone cannot fix. For example, racism, homophobia, lack of a universal healthcare system, and general underfunding of our public health structure. This highlights the dire need to address structural inequalities while simultaneously developing new treatment and prevention options. And then these options must be made available in ways that benefit people who face challenges adhering to daily pills. Providing additional tools to people who are already adherent is important, but it is unlikely to change the course of the epidemic. So I want to start with oral PrEP, which, as I mentioned, was approved in 2012 by the FDA for men who have sex with men and has since been expanded to all individuals. When used as indicated, oral PrEP is 99% effective at reducing the risk of HIV acquisition, so we know it works. However, even though PrEP was first approved nearly a decade ago, we're very far from where we need to be. Of the approximately 1.2 million people who the Centers for Disease Control say could benefit from PrEP, only 18% were prescribed oral PrEP in 2018. One metric for measuring population-level PrEP coverage is the PrEP to need ratio. This is defined as the ratio of the number of people using PrEP to the number of individuals newly diagnosed with HIV infection. And once again, I want to highlight this figure because it shows geographical disparities and that people's ability to get PrEP prescriptions is much lower in the South than it is in the Northwest, for example. There are also distinct disparities in who is prescribed oral PrEP by age, gender, and race ethnicity. You'll see here that only 12% of youth, the age 13 to 24, with PrEP indications are prescribed PrEP, even though they have some of the lowest rates of care engagement and viral suppression, and thus arguably are in the most need. Also, if you look by gender, only 7% of women who could benefit from PrEP were prescribed it, and there are also stark disparities again by race ethnicity. Also, I want to highlight that this data shows PrEP prescriptions, so the number of people who are actually taking PrEP and in a sustainable way is likely much lower. I want to turn now to talking about the long-acting injectable formulations of ART and PrEP. So long-acting injectable cabotegravir, or PrEP, is administered through a bi-monthly shot in the buttocks, and there is one shot per visit. There were phase 3 studies that were conducted, and they found that long-acting injectable PrEP was superior to oral PrEP. One of these studies, HIV Prevention Trials Network, so HPTN 083, occurred among cisgender men and transgender women, and another among cisgender women. And all of these studies found the same. that long-acting injectable PrEP was superior. I also want to highlight that phase 2 trials are now exploring acceptability and safety of long-acting injectable PrEP for people under 18, and that will include cisgender men, transgender women, and cisgender women. These studies found that long-acting injectable PrEP was safe and well tolerated, so meaning there were no associations with weight gains, interaction with hormonal contraceptions, for example, and people in non-US sites reported the highest level of preference for PrEP, particularly among women, because of an increased sense of autonomy, empowerment, and confidentiality that long-acting injectable versions could provide over oral medication. However, it is not yet approved by the FDA, but the process should begin in the near future. I'm now going to turn to long-acting injectable ART, and this is delivered each month, and there are 2 shots, cabotegravir and ripivirine, and they are also injected in the buttocks. So it's 2 shots once a month. Similarly, phase 3 trials demonstrated that the long-acting injectable version of ART was non-inferior to oral ART, and this was approved by the FDA in January 2021, so January of this year, under the name of Cabenuva. So if somebody wants to switch to long-acting injectable ART, they first have to take what we call an oral lead-in, so they have to switch to the oral medications, oral versions of these medications to make sure there are no side effects before switching to the long-acting injectable version. Also, I want to note that people are eligible if they are virally suppressed. Also, there was insufficient data on pregnant women as they were not included in this trial. An additional study that just completed and whose data has been sent to the FDA was called the Atlas 2M, the M being for months, and they found that giving long-acting ART every 8 weeks was non-inferior to every 4 weeks, which could have important implications for sustainability if these shots could become every 2 months instead of every month. Similar to long-acting injectable PrEP, those in clinical trials said that long-acting ART was well tolerated and preferred. However, I want to note that individuals who participate in clinical trials do not represent people in the real world who would be taking this medication. In fact, since we have started conducting work with people outside of trials, we found a much lower level of interest in long-acting injectable modalities. I also want to highlight that while I'm focusing on injectable versions of ART and PrEP, there are additional formulations at various stages of development that would also be long-acting, including rings, patches, long-acting pills, implants, and then potentially longer-acting forms of injections. I led a qualitative research study with colleagues in the Women's Interagency HIV Study, or WISE, which, as many of you know, is an NIH-funded longitudinal cohort of women living with HIV and at risk for HIV that started in the mid-1990s. As part of this study, we interviewed 89 women across 6 sites to explore their interest in and willingness to use long-acting injectable ART and PrEP. And I particularly want to thank Elizabeth Kinnard, who conducted most of these interviews, and Dr. Kerrigan Parrish, who worked closely with me to conduct the analyses and write the resulting manuscripts. I'm going to highlight some themes because these will come up in the case studies I'll present, and so I want to briefly touch on them here so they're top of mind. First, some of the perceived barriers to long-acting injectable modalities that came up was a fear of new and untested products. People kept saying they wanted their friends to try them first and they would wait a few years. A fear of side effects, not just from the medication itself, but the injection site, so whether there would be pain or bruising. General medical mistrust and skepticism about being injected, particularly because if there's an effect after taking a daily pill, you can just not take the pill the next day, but once you inject the drug, it's in your body and you can't pull it out. People talked about perceived challenges of getting to the clinic every month. So if you had to go for a monthly injection, there are also some challenges around fertility intentions and how it would work with pregnancy. And a lot of women said they already took a lot of pills. And so getting rid of one was not worth going to the clinic every month. In terms of facilitators, a lot of the people we spoke with said that they thought of shots as more effective than pills. So that was a benefit. Also, the ease of convenience, particularly if they were going out of town, they didn't have to remember to carry their pills in their purse, and a sense of increased autonomy and empowerment because they wouldn't have to tell people what they were doing. And likewise, confidentiality, because they could say they were going to the clinic, for example, to look at diabetes or blood pressure and wouldn't have to disclose HIV. I wanted to share this figure from a paper that I led with collaborators at the University of Miami, Miami's WISE site, to demonstrate the multi-level barriers to long-acting injectable ART use. This includes everything from insurance to the labor market, transportation, and medical mistrust. The main point I want to make with this figure is that while many of these barriers exist for long-acting injectable forms of ART, They also exist for oral art. So while long-acting injectable art will expand the menu of options, it will not eliminate all barriers. I also wanted to briefly remind people that while continued development of biomedical technologies is exceedingly important and exciting, they are not enough alone to end the epidemic. So I'm now going to turn to presenting hypothetical case studies to help illustrate potential challenges to the scale-up of long-acting injectable art and PrEP. Some of these challenges are also applicable to oral formulations of these medications, but others are unique to long-acting versions. And I'm taking this approach to illustrate how barriers can be unique for each person and how we need to tailor our approaches accordingly. I developed these hypothetical case studies based on my mixed methods and interdisciplinary research. While these specific individuals I'll share do not exist, they are grounded in the communities and individuals that I have come to know through my work. In addition to drawing on the interviews from the WISE study, I also pull from my ethnographic research in Baltimore with adolescents living with HIV, from interviews I did with providers through the Adolescent Trials Network, and ethnographic research with Black men who have sex with men in New York focused on oral PrEP. The first case I'm going to share is of a transgender woman living in rural North Carolina, which I note is not a Medicaid expansion state. She's white, has a long-term partner who's HIV negative, works at a coffee shop, and does not have a car. In addition, her viral load is not suppressed. And I'm now going to walk you through a hypothetical set of interactions that she has with her provider. The first barrier, which I'm not explicitly flagging here, is the assumption that providers will know about long-acting injectable versions of art. So we first need to make sure that all providers who see patients living with HIV are aware of long-acting injectable art, its benefits and barriers, and feel comfortable discussing it. We also need to think now about where and how patients will learn about long-acting injectable art. Will they hear about it first from their provider, a friend, a television commercial, a health department campaign? So we need to think about this now to ensure that those messages are streamlined, aligned, and comprehensive. So once a patient is interested, they must have an undetectable viral load to get access to long-acting injectable art as currently approved. So if a patient is interested but not virally suppressed, the clinic can work with them to identify what the particular barriers are and how those might be addressed, for example, side effects, transportation, or stigma. I also want to highlight the Latitude Study, which is going through the ACTG, or the AIDS Clinical Trials Group. And this Latitude Study started in 2018 and will run through 2025. And it is comparing the use of long-acting injectable art to oral art for individuals who are not virally suppressed at baseline. So in this study, patients who are not virally suppressed come for 6 visits across 20 weeks and receive ongoing social support and financial incentives to facilitate viral suppression. Then at week 24, if they are suppressed, they are randomized to either long-acting injectable art or oral art. So let's say that based on the social support services this woman receives, she comes back to her next visit and is virally suppressed. However, she's still unsure about whether she wants long-acting injectable art. However, her provider pushes for it over oral art because of her challenges adhering to daily pills. I'm pulling this example from my dissertation where a provider described putting a young woman on Depo-Provera birth control because she already had 3 children and he didn't trust her to take the daily form of birth control. And while we know that long-acting injectable art is effective if somebody gets it, we also want to ensure that they can choose the option they want without fear of coercion. One option to address this tension is to use a patient decision aid. These tools are used to support patient autonomy and to help ensure that patients can work with the provider to choose the option that best fits their needs. Decision tools provide clear information about options, are tailored to a specific patient, and incorporate patients' values and goals. Based on the qualitative research I mentioned in WISE, I received an R34 from NIMH, along with colleagues at the University of Miami, to develop a patient decision aid to help women living with HIV choose between oral and long-acting injectable art. Decision tools have been developed for myriad choices and diseases, and one very similar to what we propose to develop is for birth control and called Hello Beautiful, which I'm showing here. And it was developed by Dr. Christine Dellendorf at UCSF, who was part of the R34. So, based on this discussion, the woman decides that she wants to start long-acting injectable art, but one of the major challenges for this will be patients shifting from coming into the clinic as little as every 4 to 6 months, especially if they have an undetectable viral load, to coming in monthly. And for people such as this woman who lives in a rural area and doesn't have a car, that may pose quite a challenge. So we have to think about how to get long-acting art to places where the patient already goes, which for her may be the clinic where she receives gender-affirming care, or a pharmacy that is closer by to where she lives. Long-acting art could also be administered as part of reproductive health care visits or substance use treatment as relevant. So in this case study, based on her experiences, so coming in, discussing with her provider, using the patient decision aid, having long-acting art co-located with other care, she chooses to switch to long-acting injectable art. So I just briefly want to reiterate the barriers that I just mentioned and note that they occur across multiple levels. So the structural piece of who it's approved for, making sure providers know about it and offer it, challenges of coercion within the clinical setting, and then transportation challenges that she may face. So I'm now going to move to the second case, who is a young Black woman living in Baltimore. She's married to a partner who's HIV negative, has 4 children, and works at McDonald's. I also want to note that she has a history of injection drug use. So I'm now going to walk you through a hypothetical set of interactions that she has with her provider. So first, she is recently incarcerated and lacks insurance. One study found that at any given time, 1 in 6 people living with HIV in the US is incarcerated. And when they are released, they often leave with only 2 to 4 weeks of HIV medication and no direct link to care. For example, the state of Maine currently has a policy that suspends Medicaid during incarceration with no outreach or assistance strategies to facilitate enrollment prior to release. So this is obviously incredibly detrimental for long-term health outcomes. So we must create a system to facilitate reintegration of care for people after they are incarcerated to ensure that there is no lapse of HIV medication. So then, based on her being engaged in care, she comes in and the provider offers long-acting injectable art, but the woman wants to get pregnant and is also wary of side effects. And I also want to flag her history of injection drug use. So because pregnant women were not included in the long-acting injectable art trials, we lack data on pregnant women and long-acting injectables. So if she wants to become pregnant, she should likely continue on oral art. She's also skeptical of the newly developed drugs, especially after what happened with the Johnson & Johnson vaccine for COVID, particularly because they most affected women in her age group. In addition, she used injected drugs when she was in her late teens and wonders what it would be like to get 2 injections every month and whether that might be triggering for her. So existing research conducted by colleagues of mine and INYs, among others, suggests that a high number of women were wary of side effects related to long-acting art and wanted to wait a few years before they would try it. We also found that women with a history of injection drug use had varied responses to long-acting injectable art. Some felt they would avoid injections, while others said it would not bother them. So we need to make sure that providers can have open and non-judgmental conversations about which modality is right at the current moment, and with the acknowledgement that this will require ongoing conversations as circumstances shift over time. So then the woman is interested in long-acting injectable art, but it's challenging for the clinic to stock. So similar to the barrier in the first case study, where I said that the provider didn't mention art, I want to turn to another potential clinic level barrier. Much of the research focused on long-acting injectable art and PrEP scale-up has been on whether people will want it, but we must also examine how these injections will get to clinics, who will administer them, how they will be stocked, including potential needs for cold chain storage. Obviously, this image is for vaccines, but the ideas are quite similar. So this will be different for each clinic, especially as long-acting injectable art and PrEP move out of university clinics and into smaller community-based settings and primary care providers. There need to be clear guidelines about when it will become available, who will do the actual injections, for example, a provider in the clinic, or if the script will be sent to a pharmacy, and how the clinics can ensure that it remains stocked. So then, this woman talks about it, but it's hard for the clinic to get. She's also worried about more frequent office copays, and the clinic is hard for her to get to. So according to ViiV Pharmaceuticals, which manufactures Cabenuva or long-acting art, the monthly injections would cost nearly $4,000, and we don't yet know what will be covered by private insurance or Medicaid. In addition, even if the medication is covered, the associated medical visits may require a copay. And it's quite different for somebody who goes to the doctor once every 4 or 6 months, so would theoretically have 2 to 3 copays a year, to switch to every month and theoretically have 12 copays a year. So we have to ensure that long-acting injectable formulations of art are not only available, but also affordable. People may also need to be able to get to the clinic for monthly visits. Well-resourced clinics may be able to start with transportation vouchers, but long-term, we need to get long-acting ART and PrEP to where people are in the community. And that may be pharmacies, which, as we know, obviously give vaccinations, so usually in the arm versus in the buttocks, or maybe mobile vans. Using mobile vans has been successful in other sectors, such as providing COVID vaccines to migrant farm workers and homeless encampments, and distributing harm reduction supplies, such as naloxone and clean needles. So, given the barriers that this woman experienced, she decides that she's going to stay on oral ART. So briefly to summarize the barriers that came up for her were challenges with healthcare continuity post-incarceration, our lack of data on long-acting injectable ART for pregnant women, stocking challenges in the clinic, additional costs, fears of side effects, and a history of injection drug use. So I'm now going to turn to the third and final case, who is of a Latino gay man living in San Francisco. He's single and doesn't have kids, owns his own car, and works at the airport. However, because he's considered a contract hire at the airport, he has insurance through the exchange, which has a really high deductible. So this individual starts by going to the clinic for an annual visit, but the provider doesn't offer PrEP. So in 2019, the U.S. Preventive Services Task Force stated that, quote, research is needed to develop and validate tools for identifying persons at high risk of HIV acquisition who would benefit from PrEP. So there are significant limitations to existing HIV risk prediction tools because they require that a provider knows the patient is at risk in order to administer, and oftentimes take a long time in a busy clinic schedule. As a result, a study led by Julia Marcus, who gave this talk last year, created an electronic health records-based model to identify potential PrEP candidates. They tested this on nearly 4 million members of Kaiser Permanente in Northern California and found that it outperformed simpler models, especially for Black patients. So I want to have you look at the purple line, which is the model that she used, which in addition to incorporating measures of sexual risk and STIs and sexual orientation, it also includes things like neighborhood deprivation, substance use disorders, and psychiatric diagnoses. So this type of automated HIV risk prediction tool could help identify potential PrEP candidates who could then use a decision support tool with their provider to see if PrEP, whether oral or long-acting injectable versions, might be useful for them. So in this case study, the provider then applies this tool and the patient is flagged. So for his next visit, the provider talks to him about PrEP. So the provider offers PrEP to this individual, but he has a really low perceived risk of HIV. In public health, we often talk about populations as being at risk, as if they're static and people's lives don't change. However, risk is a very dynamic concept that ebbs and flows both in the moment and across the life course. So we need to approach long-acting injectable PrEP from a patient-centered care perspective, which requires recognizing that disease prevention may not be the most important health outcome to patients. To do this, we need to think broadly about how we create messaging around long-acting injectable PrEP and oral PrEP in order to help support people's ability to choose and also to see why they may want to incorporate PrEP into their lives. So, instead of focusing just on HIV risk or narratives grounded in paternalism, we need to think about what factors are most important to a given individual. And that may be their ability to have the type of sex they want, with the person they want, when they want, and to have that sex be pleasurable and without fear and anxiety. When oral PrEP first came out, there was a wave of stigma around how it could facilitate condom-free sex. Many of you will remember the term Truvada whores. In contrast, and to highlight an additional social side effect of PrEP access, in some cities, these narratives have shifted substantially as people are more frequently advertising their PrEP use on dating sites. So for some, PrEP use has become a marker of who is worthy of dating or having sex with. However, this means that people who lack access to PrEP can feel that their choice of sexual partners are limited because, again, they're lacking access to a form of social capital, which in this instance becomes PrEP. Also, from a reproductive justice lens, we can frame PrEP as a way to combat stigma. For example, some people may believe that a person whose partner is living with HIV should not get pregnant, but we can try and use the ability of PrEP to help shift some of these stigmas and norms. So then, based on his experience, this man wants long-acting injectable PrEP because of discretion. He doesn't want his friends to see pills, but he's afraid his insurance won't cover it. So we have to work with advocates and policymakers to ensure that long-acting injectable PrEP is covered by insurance in the way that oral PrEP now is, and equally importantly, to ensure that all related medical visits and lab visits are also covered. While oral PrEP is covered by Medicaid, not all states have expanded it, and the majority of non-expansion states are in the South, which is also where new HIV infections are the highest. Also, as you can see in the image here, while PrEP itself is covered by insurance, private insurance and Medicaid, or if you don't have insurance, if you're below a certain poverty level, it's covered. I want to highlight the fact here that the lab and clinic visits are on a sliding scale, and this could become expensive if somebody has to come into the clinic every few months for long-acting injectable PrEP, and also to get the lab work to make sure that they're not, that they haven't become infected with HIV. So in this case study, he finds out that he's eligible for subsidized medical visits and so decides to take a long-acting injectable version of PrEP. Then, after a year of injections, he decides he doesn't want to stay on long-acting injectable PrEP, so he works with his provider to make plans to shift to oral PrEP. So injectable cabotegravir for PrEP has a long half-life, which is why it provides protection for 2 months. It also has a long pharmacokinetic tail, meaning that a detectable level of the drug remains in the body for months after an injection. So this figure shows the amount of time that long-acting injectable PrEP remains in participants' plasma based on their time since last injection. And obviously there's a range, but the main thing that I want to highlight is actually how long it can exist at potentially a subclinical level, and also that there are gender differences between male participants in blue and female participants in red. While research is still being done to determine the exact clinical implications, these small amounts of the drug may not be enough to protect against HIV infection. This means that if somebody goes off long-acting injectable PrEP and is exposed to HIV while the drug is still in their system at a subclinical level, that they could develop a drug-resistant version of HIV. The current belief is that people who stop long-acting injectable PrEP will have to take oral PrEP to cover this tail. So people who miss or stop long-acting injectable PrEP, for example, they miss their visit every 2 months because they're traveling, will therefore need to have a stock of oral medications to serve as a bridge until the time they can either get back onto the long-acting injectable version or continue on oral PrEP or wean themselves off of it. So this is a complicated concept to explain and understand, and we need to make sure that providers know how to clearly communicate this to their patients, especially since this has the possibility to play out in ways we don't anticipate and in ways that could impact people's willingness to use long-acting injectable formulations of medications more broadly. So in the end, this individual starts on long-acting injectable PrEP and then transitions to oral PrEP. Similar to the previous 2 cases, the barriers in this last case occur across multiple levels, including structural, such as stigma and insurance coverage, at the clinical, provider not offering PrEP initially, and then at the individual, or low perceived levels of risk. So I'm now going to turn to some concluding thoughts. We must make sure that long-acting injectable ART and PrEP are provided in ways that people can access them and can truly make the choice between oral and long-acting injectable medications. However, I know that we are living within a limited system. For example, we do not have universal health care in the United States, and the populations most vulnerable to HIV are also those most likely to face structural barriers to employment, education, and housing. We have to acknowledge these structural constraints and simultaneously fight to change them. Otherwise, and I want you to think back to the fundamental causes theory that I started with, it will be incredibly challenging to roll out long-acting injectable versions of ART and PrEP in a way where more than a select few can benefit. We also have to ensure that the tools and technologies we develop, for example, patient decision aids, are relevant for all individuals and do not contain embedded biases that could actually exacerbate stigma or medical mistrust. The case studies I provided illustrated a lot of potential barriers, but also solutions across multiple levels. For example, transportation and insurance coverage at the structural level, distributing long-acting injectable ART and PrEP through pharmacies and mobile vans, the clinic level, making sure drugs are stocked and decision tools are implemented, and at the individual level, making sure patients understand their choices and can decide what type of version they want, or in the case of PrEP, if they want it at all. As I wrap up, I want to highlight one main thread that has come up in the research I've done so far on ART and PrEP more broadly. And for those of you who get the reference from this photo, I appreciate you. It's from the movie Field of Dreams, and I'm referencing the phrase, "If we build it, they will come." So I'm doing this to push back against the notion that we can frame HIV medication and clinical services based on the assumption that people will come to us. As I've noted, just over 50% of people living with HIV in the US are virally suppressed, and only 18% of people who need PrEP were prescribed it. Our current system is insufficient. We need to think broadly about access and incorporate options like mobile vans, telemedicine, pharmacies, non-HIV providers, and even pop-up clinics in places like churches and libraries. As I mentioned in the second case study, we have existing models that we can build off of. For example, using mobile vans to provide harm reduction services such as naloxone or clean needles, and to distribute COVID vaccines to factory workers, migrant farm workers, and homeless encampments. We also need to co-locate care and create one-stop shop for individuals, such as pairing long-acting injectable ART and PrEP with substance use treatment and reproductive health care, the criminal justice system, and even emergency rooms. I'm not saying this is easy or straightforward, but I argue that we have an ethical imperative to reach all people who can benefit from long-acting injectable ART and PrEP. In addition to the multi-level barriers to long-acting injectable ART and PrEP, so for example, awareness, access, and maintenance that came up in the case studies, I want to remind you of the transversal themes that I referenced at the beginning of this talk. We have to think about public health messaging and how to frame long-acting injectable ART and PrEP as one more addition to an existing menu of options. We also need to develop messaging around pleasure and anxiety reduction in ways that draw people in and make them feel supported and not criticized. Taking this approach will also help increase confidence in science and mitigate biomedical skepticism. We also have to limit the risk of coercion. Providers should not make unilateral decisions around who should be offered long-acting injectable ART or PrEP, particularly in ways that may force patients into choices they do not want. We must create systems that facilitate shared patient-provider decision-making so that people are truly able to choose which modality best fits into their lives. I also want to note that these tensions and the risk for coercion may become increasingly salient as additional formulations are tested, like I mentioned, the patches, pills, and implants. In closing, I want to note that long-acting injectable ART and PrEP have incredible potential, but that potential will not be equitably distributed without a careful and thoughtful scale-up that addresses substantial constraints across individual clinical and structural levels. In addition, in order to truly move us toward ending the epidemic, long-acting injectable ART and PrEP must be made available for people in the US and globally who are not virally suppressed. I want to end by returning to the example of COVID and how the cross-cutting themes woven throughout this presentation are equally relevant to that context. The challenges we face with HIV, for example, stigma, clinical capacity, and equitable medication distribution, exist for many diseases. While the structuring of research and funding streams can sometimes make it seem like diseases exist in silos, we know this is not the case. The choices we make as we scale up long-acting injectable ART and PrEP will inform how people respond to other diseases and to future epidemics. As HIV researchers, we must work with colleagues across disciplines and diseases to create solutions that will facilitate the equitable and just rollout of biomedical HIV technologies in ways that will reach all individuals and ensure that they benefit equally. So I want to acknowledge the NIH for funding so much of this work and supporting my training more generally. To the mentors that I showed in that second slide, who I can never actually thank enough, the research and community collaborators that I've had over the years, and in particular, the participants who took the time to share their thoughts and insights with me throughout the course of my career. Thank you so much for coming.
Thank you, Dr. Philbin. Very interesting presentation, lots of data. Appreciated your shout out to Julia Marcus from last year. Questions in a variety of areas. So you referred to FDA a couple of times in the first part of your presentation, noting that long-acting injectable PrEP, for example, has not actually been approved by FDA. Presumably there's an EUA so that it can be used in certain settings, but hasn't been approved as a regular medication. What further information does FDA need before they can grant approval? Just interested in your thoughts on that question.
Yeah, so my understanding is that it is in the process of being submitted. I actually asked a colleague who worked with ViiV, and that's what she told me, and that it should be submitted in the near future. So the FDA doesn't actually have the full packet of information yet. The information that we have based on the phase 3 trials that's happened should be sufficient. But as you know, it simply takes a while for it to move through the system. So we anticipate that it will be approved, particularly since the medication that they're using is already medication that exists for HIV. So hopefully it should happen at some point this year, early next year, but we'll see.
Okay, that's good to know. Another FDA-related question. You mentioned that long-acting injectable ART is approved for people who are virally suppressed, but only those.
Mhm.
What else does FDA need? Are there trials in the pipeline? Are there trials underway that would provide FDA with additional evidence so that they could expand the populations for whom that could be approved?
Yeah, that's a good question. So the Latitude study that I mentioned in the first case study is currently ongoing, and I believe about 35, 39 sites across the US as part of the AIDS clinical trials group. And that study is working with patients who at baseline were not virally suppressed, although as part of the study, they are getting them to become virally suppressed. So that study, hopefully once approved, will show the FDA that it is possible to bring in people who are not virally suppressed and start them on this. Because otherwise, like I said, while it's important that people who are virally suppressed have options, if you shift someone who's virally suppressed from one modality to the other, they remain hopefully virally suppressed. You're not actually changing anything in terms of people who are not. So I agree that it is incredibly important to try and expand who it is approved for.
Again, I'm bouncing around a little bit on questions because they come in an unorganized stream, so forgive me for that.
It's fine.
Thoughts on potential risk compensation? So increased risk after taking, after PrEP uptake. Do you think compensatory behaviors may increase, may be different with long-acting injectables versus the oral form of the medication? And if risk compensation does occur, what do we need to know about it or do about it, if anything?
So much of the research that's been done so far on oral PrEP shows that there was actually there were not changes, extensive changes in sexual risk behavior. So the idea of risk compensation, which obviously in the beginning was something a lot of people were interested in exploring, didn't end up being as much of an issue as we might have thought. So I'd have to think more about whether oral PrEP versus long-acting injectable PrEP. I don't think it would change people's behavior substantially because their effectiveness is exactly the same. It's just how long they work for. So if somebody is taking oral PrEP daily versus getting the injection every 2 months, the effect is the same. So I don't think it would necessarily change people's behavior.
Okay. With respect to the complex issues around use of long-acting injectables and covering gaps
Mm-hmm.
in order to maintain protective drug levels, are there lessons learned that we can use from long-acting contraceptives?
Mm-hmm. Yeah, so that parallel has actually been made in a lot of different studies, particularly when we came out with some of the initial ideas that long-acting would be coming, and especially with implants and patches and things as well. And I think there definitely are things we can learn, particularly around Depo-Provera, which, as many of you know, is the injection that you get and it lasts for 3 months. People really started marketing Depo as if it would make these substantial changes in how individuals access birth control, and it really didn't. Partly because of the side effects. There was weight gain, there was moodiness, and people also sometimes, there's this idea of a locus of control, of feeling like if I take the pill, I know it works, versus going to the clinic. So I think that shows an important reminder of things that we can think it will actually help, but it might not in the way that we want. So unfortunately for birth control, the parallel is, I don't want to say disheartening, but is actually quite humbling in terms of what we as public health think might happen in actual uptake. The other thing I want to highlight with birth control is it shows the need for a range of options. And so right now with HIV, in terms of biomedical prevention, right, we have daily pills and we have long acting. Obviously, you know, we have condoms and things like that as well. But for birth control, if you think we have Depo as a shot, we have implants, we have patches, we have IUDs. So really making sure we create a full menu of options so that people can find something that works best for them, because it will vary for all different individuals.
Yeah, one of the limitations with the long-acting injectables that you described for PrEP and for ART are that they, I think, both required 2 shots a month and were administered in the buttocks rather than in the arm. Is there work underway to develop something that only requires a shot less often, or that could be given in the arm?
Yeah, so just as a point of clarification, long-acting injectable ART is 2 shots once a month. Long-acting PrEP is 1 shot every 2 months.
Okay.
But the needles are, I mean, they're much bigger needles than, it's not like getting a flu shot or a COVID vaccine. Like they are quite large, and participants said it would hurt for maybe up to 2-3 days afterwards, and there was bruising. So yes, there are studies underway to extend how long the time in between shots. I mean, I truly think for all the challenges we face with these, if we can really get it to every 4 months or 6 months, or better yet, every year, that really will move the needle on where we are with HIV in terms of people living with HIV and for PrEP. And I have tried to ask around. I haven't heard as much about studies going on where it would be administered in the arm versus in the buttocks. But when we did interviews with women, and we also did like a quantitative survey, that was one of the main challenges for them. And we asked them, where would you be willing to get it? And people said, in the arm was much, much better than in the buttocks. And also in terms of scale up, if we want it to be something that's done in pharmacies or pop-up clinic in the library, that would also facilitate that.
Right, that was another question. What are the barriers to providing long-acting injectables through pharmacies, which are more commonly distributed than, or at least more widely distributed than necessarily physicians' offices? But the giving the shot in the buttocks would seem to be a major barrier to doing it in a pharmacy setting.
Yeah, that is a major barrier. There's a lot of really good research that's being done about scaling up oral PrEP in pharmacies, and that both from the pharmacist side and individuals who are interested in PrEP, that has been much more enticing as an option, not just because it's easy to get to, but there's something about walking into a doctor's office that feels very different than going by a CVS or a Rite Aid. I think we've seen with COVID that the capacity for pharmacies to really increase the scale up and distribution of, vaccines, of injections more broadly is there. And so I think for some of them, there may be ways to create a space. It probably would not be every pharmacy, but maybe there would be some pharmacies in cities where there is an additional space where that could happen. So I don't think it is easy, but I think it is possible.
Different kind of question. Are there data related to how long it takes before effective concentrations of these long-acting injectables are achieved? How long until people are protected once they start taking PrEP? We've all been hearing, geez, you have to wait 2 weeks after your COVID vaccine before your antibodies get up to a decent level. What is the situation with long-acting PrEP or ACT?
That's a good question. I'm not actually sure the exact length of time that it takes. I don't believe it is very long, but I will have to confirm that.
All right. You've identified a lot of barriers to long-acting injectables, in addition to highlighting benefits, and many of us can imagine the benefits quite easily, and we appreciate your working through many of the barriers. Have there been modeling studies, agent-based modeling or other kinds of modeling studies to evaluate the potential population impact given this large mix of barriers and benefits?
People have started, but I think the main issue is most of the data we have is from clinical trials, and the participants in clinical trials obviously do not represent the general population. And so while the majority of them were incredibly enthusiastic, there were few dropouts. That is not what we've seen. And because long-acting injectable even though it's been approved by the FDA, is not readily available, and long-acting injectable PrEP is not yet approved, everything we're asking people is hypothetical. So people are starting to do the modeling studies, but I would say we need to interpret when those results come out with a little bit of not skepticism, but we just have to take it with a grain of salt, because asking somebody, would you be interested in this, versus them actually doing it for 6 months and then us having the data of how well that actually works and using that to model are quite different things. So we know in terms of doing behavioral research in public health that what people think they'll do and what they actually do often is not aligned.
Right. We have a note from one of our participants that the current HIV pipeline includes development of implants and more potent drugs with preliminary data suggesting delivery of protective drug levels for as long as a year. And that would be a huge boost in this area. I'm sure you would agree.
Yeah, so like I mentioned, there are multiple things in the pipeline. Some are in phase 2 trials, some are in phase 1. including patches, implants, longer-acting versions of injections, monthly pills, and some of those. So for example, the implant for PrEP, which would be biodegradable, it would just sort of dissolve into the arm, would be for 6 months. So there definitely are longer-acting versions that are coming down the pipeline. And I do think that once we get those, some of the structural barriers, while still there, will become less salient, because if you only have to go to the clinic once, every 6 months, that is quite different. Or if it's, an injection in the arm that lasts for every 6 months, that could be done, in a library, for example, with a public health nurse, versus having to go to a clinic.
Right. Well, Dr. Philbin, I want to thank you for a terrific presentation. I want to thank the audience for submitting interesting questions. As I mentioned earlier, we will be posting the slides and a recording of today's presentation on our website next week. Everyone who viewed the webinar will receive an email with a link to the recording when it's available. Please share the link with your colleagues and friends so that others can enjoy it. And I want to thank everyone for joining today's lecture.
Thank you again for having me.